Hello, everyone. Welcome to our 9th seminar of our Frailty seminar series. For those who don't know me, my name is Olga Theou. I'm a Frailty researcher from Dalhousie University in Canada, and I will be the moderator for today's session. Today, I'm very excited to introduce you to a great colleague, Dr. Romero-Ortuno. Dr. Romero-Ortuno is an associate professor in medical gerontology at Trinity College, Dublin, and a consultant physician in St. James Hospital in Dublin. And I also want to emphasize that in addition to his several clinical research degrees, he also has a music degree from the Conservatory of Barcelona. He worked as a consultant geriatrician in Addenbrooke's Hospital, and during that time, he also had an honorary visiting fellowship to the Clinical Gerontology Unit of the University of Cambridge. Dr. Romero-Ortuno has clinical and academic expertise in frailty, dementia, delirium, and comprehensive geriatric assessments. He is a faculty member of the Global Brain Health Institute, and he also co-chairs the Frailty and Resilience Working Group at the IRIS Longitudinal Study on Aging and the IRIS Frailty Network Interest Group of the Irish Gerontological Society. He is also the Associate Director of Postgraduate Teaching and Learning in Trinity School of Medicine. His research contributions to the area of frailty has been recognized with the 2015 British Geriatric Society Rising Star Award, the 2017 Count of Cartagena Award from the Royal National Academy of Medicine of Spain, and the 2018 President of Ireland Future Research Leaders Award. And I can talk even further for his bio, but I think we can go even to his presentation, today, Dr. Romero-Ortuno will present on the new insights on frailty. As I said, the presentation will be approximately 40 minutes, and we'll then have approximately 15 to 20 minutes for discussion. During the presentation, you don't have to wait until the end. During the presentation, you can add your questions to the Q&A tab that for most of you should be at the bottom of your screen. And also only use the chat if you have any technical issues. Don't use it for questions or comments in the chat function. And I would like now to invite our presenter to share the screen and start the presentation. Thank you.
Well, thank you very much, Olga, and thank you very much, Jorge, as well, for the very great invitation to be here. And I hope everyone can hear me and see me okay. And it's delightful to be here amongst a group of people who really are excited in the area of frailty. And I was tasked to speak about new insights on frailty. And I was reflecting on how to address this webinar, and I thought perhaps the best thing to do would be to reflect on the concept of frailty and just spend a little bit of time to see what is old, but at the same time new about frailty, and to see what are the main concepts or insights that, without being new, are important to highlight and reflect. Of course, I don't know your backgrounds. I don't know, what optics you see frailty from. And in that light, I think I'm going to try to cover a little bit of the concept first. So for various reasons, you've come today to this webinar interested in frailty. And you've gone through a series of webinars that have seen frailty through different lenses, different ways of measuring it, and different ways of applying that in clinical practice and research. And today, I just really wanted to go back to the basic concept, first of all. So just really reflect on the fact that as we get older, a large segment of the older population really is quite fit and robust. And age is not really necessarily a synonym of frailty, and frailty is not necessarily a synonym of the way we age as individuals or our societies, because of course, as populations get older, there is a widening range of function in individuals, and we are very different individually, even though we are of a similar chronological age. So this concept of biological age or fitness versus frailty spectrum is way more useful than considering age in terms of chronological terms. So, of course, you know, the way we age is conditioned by many different factors. And of course, as we transit through our life course, there are a lot of influences that we are subject to. Of course, you know, we are genetically who we are of certain sex and hereditary factors. And that it gives you the more deterministic or nature part of our aging trajectory. But I would argue that increasingly evident, these genetic or unmodifiable determinants are less important than what we call the wider determinants of health. And so what are those wider determinants across the life course? So our individual lifestyle factors, our social and community influences that can be both positive and negative over the life course, and very dynamic. Living and working conditions, again, could be very dynamic and act as a double-edged sword on our trajectories of aging. And of course, the general wider socioeconomic, cultural, environmental conditions, which have to do with policy, public health, and the wider societal aspects. So all that dynamically and in a bidirectional way does influence the way we individuals age. So it's not surprising that because all those factors impact our individually in a different way, we all age differently, and regardless our genetic predisposition or our unmodifiable factors. So that is probably why populations are getting more heterogeneous as we age. It's all very complicated, isn't it? Of course, you know, that concept of frailty comes in as a niche specialty because, as I said earlier, frailty is not applicable to the majority of older adults that live in the community. In fact, you will have already learned that most older adults living in the community are not frail, and they don't recognize themselves as being frail. So this concept of frailty comes from clinical practice, where we are more likely to see people who've got health problems, and perhaps if have aged in a more complicated way, and they are seeking medical help, you know, at a particular age. And so, of course, clinicians see more frailty than someone who is not a clinician would see frailty in the community. So, and of course, frailty comes out of a clinical concept. So the clinical concept can be fine-tuned and tweaked, but people who were talking about the concept of frailty in the late 1990s, and this one is perhaps one of the earliest definitions that exist around the clinical concept of frailty. And it was defined as a condition or a syndrome which results from a multi-system reduction in reserve capacity to the extent that a number of physiological systems are close to or past the threshold of symptomatic clinical failure. And as a consequence, the frail person is at increased risk of disability and death from minor external stresses. So here we've got a definition that A, does not take age into account, B, that it is a dynamic definition involving a baseline situation, an acute stressor, and a response to that stressor, and C, that it talks about multiple system deregulation. So it is when various different physiological systems are not optimally working. So how you model that concept is actually quite difficult. So all this research that has emerged since the early 2000s has really tried to operationalize this complex, multifaceted concept in a way that it is easy to apply in clinical or research practice. But new insights on frailty, I suppose, have to do with retaining the concept of frailty and then try to elaborate as to how we can add value to new ways of measuring or experiencing in frailty, but retaining the original concept that was proposed. This is obviously different from multimorbidity because multimorbidity is not really put in the context of a stressor, and it is different from disability because, of course, this frailty clinical concept does not really require any particular disability baseline, but you can understand how these concepts are related. You've seen this slide quite a few times, I suppose. If someone is robust, you are actually having a very independent baseline. You have a very high level of functional ability, and that stressor, illness, trauma, or any stressor impacts on your physiology, and you bounce back very quickly to the same pre-morbid baseline. However, if you are living with frailty, you may be independent and you may be above that functional threshold of dependence. But when the same stressor impacts on your physiology, then you're going to decompensate more easily, and the recovery will take a little longer, with a risk that it may not recover to the same baseline. And you may still be independent after the recovery, but you may recover below a threshold where you become dependent on others. And so the real crux of the issue is how we actually reduce the impact that the stressor has on the physiology, and B, more importantly, is how we promote a quicker and more integrated recovery, having had that stressor impacted, and C is how we can actually prevent stressors from impacting the physiology in the first place. And those are the big questions for frailty, aren't they? Of course, the big questions on frailty are those, but what I would like to do as well as an educational activity here is just recap a little bit on various ways where colleagues and academic colleagues and clinical colleagues around the world have tried to approach the concept of frailty. I'm just going to briefly illustrate three main operationalizations of the concept. One is a very useful one called the Frailty Index, and then there's another very useful one that looks at frailty as a syndrome. And then there are other approaches. I'm going to talk a little bit about the clinical frailty scale. Of course, the Frailty Index, you have seen it, and we owe it to Olga's group. Here, a very kind introduction, Olga. And really, a lot of people have been thinking about ways where you could create a tool that is easy to develop and easy to apply in clinical practice, where you would capture that heterogeneity of aging. And you think that that might be a very difficult thing to achieve. But look, a standard procedure was put forward a while ago in the early 2000s, looking at the concept of health deficits. So health deficits are things that may or may not be present in an individual, and they accumulate with age, and they don't saturate too early, and they're measured across a wide range of systems. And of course, they are, things that could be easily measured. They can be disabilities, they can be comorbidities, they can be symptoms. They can also be even laboratory abnormalities, where you get your list, and then you get your individual. You look at the individual more or less comprehensively, and you establish how many of those deficits in the list your patient or your participant in front of you fulfills. For example, here I operationalized one in the Survey of Health, Aging and Retirement in Europe. And as you can see, there are disability items, there are comorbidity items or morbidity items, there are symptoms, even self-reported health, and there are functional measures like functional performance measures. So of course, if someone that is in front of you has 2 out of 40, well, that's the frailty index of that person at that particular time. Again, it's a simple construct. So it's a frailty index is the sum of deficits that you have considered divided by the total of numbers. So it's a sum of deficits that are present in the individual divided by the total number of variables that you have considered as health deficits. So of course, you might think that that's not rocket science, and that's going to be imperfect in clinical practice because sometimes it's difficult to establish whether a deficit is present or not. Interestingly, obviously, they say that there is a limit to accumulation of deficits. And of course, when more than 70% of deficits have been accumulated in a particular individual, then constantly and consistently in epidemiological studies worldwide, we see that there seems to be an accumulation of deficits at about 70%, above which people are less likely to be alive and to survive. So it's interesting that may have some biological substrate. And again, we did operationalize that frailty index in SHARE. And of course, those 40 deficits make a frailty index that's here represented on the y-axis. And on the x-axis, we've got the chronological age. So back to that concept that chronological age and frailty or biological age are actually correlated, but not really the same. And that is showing here very clearly in a graph on the left that contains 16,000 females, and on the right, more than 13,000 males. And you see that there is a wide degree of heterogeneity between frailty index and chronological age. The correlation coefficient is significant, of course, with an effect size of 0.2, which is actually mild effect size, but you can see people who have accumulated very few deficits at the age of 90 plus, and people who really are, have accumulated quite a lot of deficits, at the age of 50 and 60. So there is a huge heterogeneity in relation to biological age versus chronological age. If you look at prospective mortality rates at 2.4 years, then you can see that the frailty index is quite useful at arranging biological risk within chronological age groups. So you see, for example, here that people who were in their 90s but had a low frailty index between 0 and 0.1, the 2.4-year mortality rate was only to 8.7. And that was actually lower at the age of 90 than the mortality rate of people in their 50s who were at that time at frailty index of 0.5 to 0.6. And you can see that there is an interesting ordering in terms of the biological risk, which might be useful to then study what is driving that biological heterogeneity within chronological age categories. So that is actually a very useful way of offering a concept and of offering a tool that approaches the concept of frailty. Of course, frailty is dynamic, so that the fact that someone has a given frailty index at one point in time does not mean that that is going to be the same. And one of the things that has evolved in the last few years as well is the concept of dynamism in frailty trajectories and frailty transitions. And that's an important point to take into account. Of course, frailty phenotype is an alternative operationalization of frailty. It's based on a biological model, a phenotype model, where key items like undernutrition, sarcopenia, reduced muscle strength, reduced metabolic rate, slow gait speed, low levels of physical activity are involved. And in that kind of vicious circle, then giving rise to the classical manifestations of frailty, for example, impaired balance, falls, and a trajectory towards disability. So that is a model that conceives frailty as a pre-disability state. Whereas, and this is an important point, with the frailty index, deficits can include disabilities. So you may capture clients that are slightly more disabled. In terms of a frailty phenotype, the idea is that you capture people who are not yet disabled, but they have a number of morbidities that might make them more vulnerable to decompensation. So one of the key points that I want to make today, and is not a new insight, but it should be reflected on, is that every time we label a client, a participant, or a patient with frailty, which is not a diagnosis, essentially we should really specify what tool we are thinking about when we adopt that label, because of course, phenotypically, someone who is labeled frail as per index may not be the same type of person that's labeled according to the frailty phenotype. So it's very important to specify. Both operationalizations do retain some faithfulness to the concept of frailty that I alluded to in the beginning. Of course, none of them really incorporates the measurement of the stressor and studies the way that physiological system compensates after the stressor compared to the baseline. So even though they are important ways of looking at frailty in terms of chronological versus biological age, tools are different in terms of how they see frailty in relation to the disabling process. And also they are really kind of asking you to make a bit of leap of faith in terms of understanding how the physiology dysregulates with a given stressor that sometimes is very difficult to measure. One of the things we're doing in Trinity College Dublin is put together an educational module on frailty, where we really eclectically and systematically go through not only those two, but a lot of different operationalizations. And we look at their advantages, disadvantages, and how they might apply differently for particular settings and in different purposes in clinical practice and research. As I said, the clinical phenotype, the frailty phenotype, boils down to 5 cardinal features. exhaustion, weakness, low physical activity, slowness, and explained weight loss. And if you have one or two of those items, you're classified as pre-frail. And if you've got 3 or more items, you're classified as frail. One of the things that I was reflecting to sometimes in front of medical students is that, well, look, it is true, in the last month, I have had low levels of physical activity because I've been preparing an academic paper or a grant. So my physical activity levels have been reduced. And yeah, I mean, I feel a little bit more exhausted. And so actually, if you think about it, 1 or 2 of those items make pre-frailty. So at any given point, I would have been classified as pre-frail. But that does not necessarily mean, hopefully, that I've got physiological dysregulations and I'm more vulnerable to stressors, although it might mean it, So the point is that some of these frailty classifications are quite sensitive, i.e. they will identify frailty or pre-frailty with relative ease, but they might be less specific, which means that obviously, that I am pre-frail may or may not mean that, I've got, physiological vulnerability to a given stressor. So that's an important insight that I would like you to take today. But of course, if you look at that indirectly from the point of view of epidemiological studies, well, the same as seen in the frailty index, the correlation with prospective mortality is very strong. And, that is independent of big, suspects like age, chronological age, of course, comorbidities and disabilities. And so essentially, it does really become a tool that can be valuable to stratify risk. And why would you like to stratify risk is because you would like to offer resources to people who need it the most. So today we are in a situation, today and always, I suppose, a situation of waiting lists, situation of really kind of clinicians and managers really trying their best to make sure that those who need the service sooner can access it sooner as a matter of equity of access. So if you did have a way to stratify the risk for those in your waiting list, so then you would be more equitable, and perhaps, having a stratification tool like a frailty tool might help you to offer the service to those who that they're going to decompensate a little bit sooner. So that's a new insight that I would like you to get as well. And so sometimes one wonders about the practical value of frailty tools. And sometimes, they are very valuable. Sometimes they don't add value. So think about frailty tools in a way that they would be a good thing to have when they do add value. Of course, the frailty phenotype is a precursor of disability. So please stay with that message as a new insight, which is not new, but as an integration of your knowledge that frailty by phenotype tends to capture people who do not feel frail, because they're not disabled. And if they hear that you've labeled them as frail, they might just get very worried, right? Because actually they're not disabled, they're not really fitting with that image that sometimes, people have of frailty. One of the things I'm going to say later on, I think it's worthwhile reflecting on, is that the concept of frailty can be very negative, and people can feel, very upset about the word frailty and what it might mean. Because how we see frailty in clinical practice is actually the opposite, but sometimes people have different perceptions, and it opens up an opportunity for dialogue and about, making sure that we actually are on the same page around what we mean by frailty and what are we going to do about frailty if we mention frailty and we bring that into the conversation, right? Frailty phenotype might be a very useful one to prevent disability, for example. Whereas, frailty index may also include disability, might be useful as well, but it's a different combination of ingredients or geriatric syndromes in the definition of or operationalization of that concept. One of the things it's really important to reflect on, and again, is a new but not so new insight, is the fact that frailty is very dynamic. And one of the things that happens is that people think that frailty is a diagnosis, and frailty is equivalent to saying, well, look, you've got diabetes, or you've got ischemic heart disease, or angina, or a stroke. It's not the same, isn't it? Because frailty is a concept that is not really in the international classification of diseases, and it really shouldn't be, because frailty is driven by different diagnoses in different people. It's not a diagnosis in itself, right? It's a syndrome, it's a state, it's a situation, it's a concept, but not a diagnosis. So frailty is a portal to find out what is driving that frailty. And in one particular subject, frailty may be driven by being tired or overworking and nothing else. But in other cases, it might be maybe an indicator that perhaps a cancer is developing, or or a depression has developed, or perhaps there is an osteoarthritis that leads to low levels of physical activity. Someone who was waiting for a double knee replacement, for example, was frail, not only objectively by different tools, but also subjectively as well, because the person was really, affected by that disability. And of course, a bilateral knee replacement could all of a sudden bring that person back to robustness immediately. And this is what happens. So important to reflect on what are the drivers of frailty in individuals, and also that the fact that, someone can have hope, that if you mention the word frailty, then the next step is to find out, what are the drivers of that frailty, and what are we going to do to try to get that people out of frailty. And that's what we call the comprehensive geriatric assessment. And that's really the message for geriatrics, because geriatrics has always been there to try to ameliorate or look at what's potentially reversible in a geriatric syndrome presentation. So frailty appears as a geriatric syndrome in that way, in terms of what can we do about it that we haven't considered before. And not all frailty, of course, is ameliorable and reversible. But without having thought about it and without having had the systematic approach to the assessment, then, we can't really, give up and say, well, look, we're frail, so therefore there's nothing else we can do. And a lot of that perception of frailty is new, and because a lot of different disciplines have talked to us, clinicians, to say, well, look, the way you talk about frailty when I hear you is quite nice, and I think I understand what you're saying, but before I heard your talk, I thought you were going to tell me that, you are doing palliative care, So let's be careful about the perceptions of frailty, and not that we need to change the terminology, but we're very lucky because we are in a field that actually encourages us to discuss our concepts with other people that might see it differently, and that's always a positive thing, isn't it? And of course, a clinical frailty scale is a different measure. Many of you may have seen this. And why do I illustrate clinical frailty scale? Because beyond academic debates and biologically based models, or perhaps more, academic based models, there are also ways where clinicians are interested in have quick insights into frailty that are very practical and applied to clinical practice. And of course, there are tools that appear that actually try to help clinicians and even borrow their clinical judgment into the scoring. And really, not only doing that, but also, as Olga has very kindly and nicely demonstrated in some of her recent papers, is educate clinicians in terms of how to conduct a basic comprehensive geriatric assessment, or a geriatric assessment in an acute care context, where, almost algorithmically, or with a classification, with a mental classification tree, you could really gain a better, more efficient knowledge of that person's baseline. And you could really utilize that to try to stratify the risk and try to predict what is going to happen in relation to the current situation after the stressor has impacted, and what services and resources that person might need compared to someone else who might not need it that much. And of course, the clinical frailty scale has been really helpful in that regard. Also, as well, is open a dialogue with people who start to think about it, especially outside geriatrics, because we really try to capture the baseline. And sometimes, the clinical frailty scale is a little bit misunderstood, because, we think that it's going to give us the answer right there in front of us as an eyeball assessment, and it's not. It's really a guide, a prompt to really conduct a small bit of geriatric assessment with attention to symptoms, disabilities, morbidities, cognitive symptoms, perhaps history of dementia, how they manage activities. And once we know the person at baseline before they had the stressor on them, then we really then utilize our clinical judgment prompted by the text and the pictures, but mostly by the text, to really assign a number and leave that number behind to see if they could really add value to the management, because that's another leap, is how that might add value. So the clinical frailty scale is interesting. It captures baseline. The text is more important than the pictures, and but it could be a very nice way of adopting a way of doing a geriatric assessment when you weren't used to do that before. And it can happen quite quickly. And I think a lot of people who came into geriatrics through the clinical frailty scale that never thought geriatric before thought, well, actually, it's a nice prompt. I mean, I understand how you do it, and I'm getting more and more confident now. And I think that frailty outside geriatrics is so important, and really one of the things that frailty has given us is the opportunity to talk about frailty with non-geriatric specialists. I don't know how many of you are geriatricians, how many of you work in gerontology, and how many of you do not. But I think really converging interests and talking frailty around that point is an important opportunity to dialogue. And of course, the best care plans in clinical practice are the care plans where there's been dialogue and there's been an opportunity to understand where the person comes from and what are the care preferences and the values, and without opportunities to converse and discuss, then we miss that. And sometimes we miss that to the detriment of not only the patient, but the system as well. You might think the clinical frailty scale is not rocket science. One of the things that's new or not new about the frailty is the idea of how actually interestingly robust appears in the numbers when actually think about the concept, and it seems quite fluffy. So I was working in a hospital in Cambridge that routinely started to operationalize clinical frailty scale in those age 75 plus admitted non-electively to the acute hospital in every single specialty. And they had to have a clinical frailty scale done within 72 hours of admission as part of an incentive called sequin in the NHS from the clinical commission groups. And all it boiled down because the GPs, the general practitioners, wanted to have some metrics of complexity or need to see who was more at risk to be readmitted to the hospital. So therefore, who needed an earlier intervention post-discharge, for example, in the community. So that's how, a clinical frailty scale started to happen in the hospital as a routine measure. And some people really were quite keen on it. And some people would say, well, look, what's that for? Is it going to be accurate? Is it going to be, well, with a bit of training and a bit of dialogue, that it can be quite accurate in terms of retest reliability. But some people were skeptical, including myself, I suppose, but what happens when you join clinical frailty scales like that in a real world setting? More than 5,700 clinical frailty scales done over a period. And when you look at, say, inpatient mortality rates, and this is complete crude unadjusted data, it almost looks mathematical. And so there is an exponential curve, an increasing risk of inpatient mortality from 2-3% to over 30%, and it really has a logarithmic incremental there on this series, which was very surprising because it looks informal, it looks reasonably inaccurate, but then the numbers speak by themselves. And similarly, with length of stay, you've got a very interesting and astonishing linear increase. And length of stay has become a big drive for hospital managers. Of course, reducing length of stay is so important because the experience of a hospitalization can be very detrimental. Olga knows that very well, Jorge as well, in terms of the conditioning work that's very linked with frailty. And that's all new in the last few years. I really try to avoid hospitalization when it's avoidable. Sometimes it's not avoidable. Sometimes, when it's not avoidable, as I said earlier, you try to minimize the process of recovery. So you try to maximize recovery, minimize the length of the recovery. And, operationally, that translates in length of stay. And, everything we can do to really speed up that recovery, then it's very appreciated by patients who really don't want to be in the hospital by and large, and they get distressed and sleep deprived and deconditioned. So thinking about length of stay and how that relates to complexity, but is very important as an intervention. But look at the signal that we got from the clinical frailty scale in that series. So very, very interesting to stratify risk. And clinical frailty scale behave better than other routinely incorporated measures like comorbidity scores, of course, dementia on its own or a cognitive concern on its own, and even age, of course, age having a very poor predictive value on the grounds of this big heterogeneity that we've got in populations that's known. So adding value, so the frailty adding value, it's actually a very important thing to pursue. When frailty doesn't add value, then why should it be promoted? But when frailty does add value, then why would it add value in that care setting? We did see, for example, how naturally people who were over 75 with higher clinical frailty scores were more likely to be allocated to a geriatric medicine ward, which is where we do the comprehensive geriatric assessment, which is what's really known and evidenced, to reduce length of stay, to make people more likely to survive, to make more people make people more likely to return home. So that resource is quite precious because we only had 150 beds in a hospital that has over 1,000 beds. So the number of geriatric beds was very limited. So was that a focus, for stratifying who are the over 75s who really would benefit first from accessing a geriatric medicine ward, and also given the level of complexity when you accumulate, clientele in that regard, do we need more resources in the geriatric medicine ward? Because of course, the nursing to patient ratio perhaps needs to be higher if you understand the complexity. So the ratio, has to be adjusted to complexity, because as you accumulate complexity in one area, you may have the right method, but you need more resources as well to cope with that extra demand. And managers do understand that, those dialogues that I'm referring to. Well, it's very nice and rewarding to have them with managers and policymakers when it comes to easy metrics that everyone can understand, conceptually. So that's how Frailty also has added value where it's been operationalized, because it's being raised to nice discussions. How else is Frailty useful? So you might then go back to that concept of the stressor. And so far, we haven't really talked about the impact of the stressor. Very important, because, the Frailty concept requires a stressor. So you might think, so what is a stressor in acute care? So the stressor in acute care is the acuity of illness. And the acuity of illness is independent to the baseline function, which is before the acuity of illness hit the individual. So how do we measure acuity of illness? So in many hospitals, they've got these early warning systems. So early warning systems are based on heart rate. So if it's too low or too high, then it gives you higher points. Blood pressure, again, too low, too high, higher points. Respiratory rate, similar. Level of alertness, and that includes cognitive concern or delirium as well. So more points for delirium. And temperature, so hypothermia, hyperthermia, fever. So of course, you imagine that you accumulate more points, and the more points you've got on the early warning scores, the sicker you are, acutely ill you are, right? So that's one dimension. That's a dimension of acute illness severity. So if you go back to the concept of frailty, so you've got a baseline. You've got a baseline that can be measured with a clinical frailty scale. That's, if people have been trained correctly, it's a pre-acuity baseline. So you've got that there. So the clinical frailty scale on the x-axis, with their pictures. And of course, on you could stratify, people according to baseline frailty levels and how sick they are. So for example, there is a cutoff. So if you get more than 4 points, then the nurse, as per escalation policy, has to call the doctor, and the doctor has to come within 30 minutes. So this is the escalation policy, and there is a cutoff above which then the nurse has to make the call, because the patient might be unwell and something might happen acutely, right? So if you stratify, frailty by levels of acuity, so low acuity versus high acuity, so you know that those over 75s who have low acuity, well, they're going to have a modest increase in the mortality rate in the hospital, could go from 2% to about 5-6%, and that's really kind of moderated or by levels of increasing frailty. And that's at the low acuity level. But if you actually look at the high acuity level, the same 75-year-olds will actually have a big additive, risk in terms of how the risk of mortality as an inpatient might develop. And it's not really interactive, but it's additive. It's in the big addition of risk. So I was thinking that could be really like a still indirect evidence, but more in tune with the concept of frailty, where you've got a baseline, you've got a measurable acute stressor, and of course, mortality is a big outcome that doesn't really tell you how the physiology did dysregulate, but it actually indirectly suggests that it dysregulated to a catastrophic level, right? So that's really how, we would like to approach the concept of frailty, operationalizing it in a way that is more faithful to the concept of frailty, incorporates that dynamic stressor and the baseline, the response, and it's a bit more specific in terms of, signaling real physiological dysregulation. Well, I'm not going to give you more new insights on the research that's doing, but I will suggest to you that there is a lot of research evolving in the area of refining frailty tools from a physiological point of view. And as I said, look, a new insight on frailty would be to try to think about ways to come up with more specific frailty tools that capture its dynamic nature, that capture the stressor that's required in the definition, and actually become more translatable in clinical practice. It could be widely used, for example, when we are planning a stressor, like an operation or a big chemotherapy, or when the stressor has been unplanned, so an accident or an emergency as well. And that could help us, stratify risk and also make more individualized plans. So, so that would be a new insight that's not new. So that's the topic for today, new insights that aren't new. But I'm just really kind of reflecting, hopefully to open a nice discussion. I'm not sure how I'm doing for time, but what frailty assessment tool? So the message I've got for you today is that there are many, and they are complementary. They're complementary, but they're not the same because, one frailty tool might see frailty as a pre-disability concept, and the other one actually might think of frailty as an end-stage disability. And some frailty tools might capture, socioeconomic or psychosocial aspects, where other frailty tools might only capture physical performance measures. And so essentially, and we've got a whole, postgraduate course here in Trinity looking at, what every tool does, what geriatric syndromes are captured, and of course, they all could be useful and indicated in different situations. So one of the big questions I get all the time is, doctor, that you have studied frailty and you seem to be doing some research on frailties. Well, what frailty tool do I need to implement in my clinical practice? And the answer is actually education, and the answer is actually reflection, so that the same person who is asking the question can then answer their own question with a little bit of educational facilitation, and by appreciating that, very different tools have very different ingredients and can be applicable to different scenarios. And that is a thought process that every one of us has to have. Of course, then frailty has to add value. It has to really end in an outcome that's really person-centered and service-centered. And of course, those are the requirements for frailty to be successful. So think about frailty tools in those lines, and sometimes if you're not sure, go and compare, try few at the same time and see which one gives you the most joy, and then stick to the one that has added the value. I really like this paper that Olga, published a few years ago, and it's really one of the first papers that actually showed this heterogeneity in frailty tools. And sometimes people interpret these papers, even though this was a really well-focused paper, sometimes people think that, frailty is a bit of nonsense because, different frailty tools capture, a very wide different prevalences. And so the Share Groningen is there up to almost 50% all frail, whereas the frail scale is actually, less prevalence. Well, that's correct, because you are not really thinking about the same geriatric dimensions, and they are capturing different types of people. So of course, not surprising that the prevalences are similar, but for today, in one of your purposes and in one of your settings, then indicator B will be the good one to use, because you want to be a bit more screening approach, more encompassing. Perhaps you're very interested in socio-economic aspects or psychosocial aspects because of your particular interest or who you want to capture. But the next day, you may be interested in identifying those who've got the more biological risk, and they are within the minority. So you might be looking at a tool that's more specific. So it's up to you, isn't it? And so it's not really that we think about the same frailty. Is that there are different types of frailty that we're measuring with different tools, and that's why it's so crucial that every time you mention the F word, that you specify what tool you are thinking of. Otherwise, people get very confused, and you look at the literature and you'll get very confused, that you think that we're talking about the one frailty, but actually we're talking about various different frailties. And I hope I'm not too controversial here. So the best way I could, think about this is looking at an iceberg. So I don't really particularly like iceberg theories, but this actually was particularly applicable because think of an iceberg, think about, you going in the Titanic and you think about, not really seeing what's ahead of you and being in the dark. And of course, having a system of radars or sonars that, scan the water ahead, and they will let you know if there's something hard that you really need to maneuver out of. And so that's really what Frailty tools can do. So you could have Frailty tools that have a wider sonar and let you see almost the whole iceberg. Multi-dimensional tools that have very wide prevalence. And that will let you see the iceberg, as well as maybe something that might be a bit more narrow focused, that if it's a really big iceberg, you still get a signal back to say, look, out of here, because there's something of dimensions unknown that's very hard, and so please, before it's too late, maneuver and change the course. And that change the course and maneuver is the consequence of thinking about frailty, and is what really is required. So you see, so if you did a comprehensive genetic assessment and have the time to do the whole aerial and underwater view, then you will get a comprehensive picture of what is going on. But you may not have time to do that. You may just really need to scan the water, with a sonar, would be wider or narrower. But that's how it could be useful. And so that's really something that I think I put out there as well. Not sure if it's a new insight. It's probably an old insight as well. But I believe in old insights that have to be discussed and reflected upon again and again. So that's why different frailty tools have complementary value. They're not the same capture. You don't expect them to have the same capture, but they could add value in different scenarios. And that's why it's so important that we understand, what is on the tin, in the tin. And you look at the ingredients and you say, well, look, I understand what I'm going to be opening now. Because of course, frailty is one dimension, but as we mentioned, acuity of illness is another dimension. Some frailty tools capture cognition, as we saw in the clinical frailty scale. Don't forget the right button text, which is the most important as well. And some tools do capture morbidity, some of them don't. Some of them capture the social, psychosocial, socioeconomic, which is really big in the social determinants of health. And the real complexity is at the intersection of all that, right? But perhaps you have a focus for one or the other dimension, and remember that frailty is that dimension that captures the vulnerability. So you do need the stressor. Maybe you're not interested in the stressor, so you may be happy enough with morbidity and disability, acuity, and that's it. But I think I would argue that we need to do a lot more in terms of refining the concept of frailty. It's a dynamic concept that reflects a vulnerability to a stressor. How do you manage frailty? So that's really the crucial aspect, really. So it's changed. There was individually tailored interventions that preserves that independence. A function is everything. So retaining functional capacity and good quality of life, despite aging and everything else, is really the holy grail, what we want for ourselves as well. So essentially, this is how frailty comes in. This is a portal to identifying problems that are potentially remediable. So at the population level, what can we do? So activity programs, physical activity, nutrition, health education, practical social support. So even though the certainty is low for outcomes in systematic reviews, actually, it's the best we can do at the population level. But of course, at the individual level, the most important thing is do the geriatric assessment to identify what is the driver or drivers of that frailty, and then identify systematically what is potentially remediable. And that is really what's going to bring that person up, if possible. Even at the primary care level, so what is been evidenced as being effective, but also feasible. So again, similar thing, strength exercises, nutritional supplements, health education, practical social support. and really is accessible at all levels, so hospital, primary care, and not only, you know, the domain of medics, but all alike health professionals, even non-health professionals as well, you know, can gain that awareness of awareness of identifying risk and detecting frailty that needs further unraveling, and then refer to our professionals, in combination. So in the hospital, the comprehensive geriatric assessment, as I said, has been shown to improve outcomes. So, but sometimes the resource is limited, and sometimes frailty can serve as a tool to make sure that the access to the limited geriatric service is as equitable as possible. And that could also be the case in non-hospital settings, because you see, early access to a specialty is crucial. So people do better if the right professionals are seeing them as soon as possible. How else is frailty adding value? So you may be in non-geriatric specialties, and of course, you know, one of the first papers that came in the area of frailty and surgery, or oncogeriatrics as well, is actually the fact that, you know, in surgery, for example, a combination of frailty measures with the usual suspects, for example, the ASA scale for surgical outcomes, actually was adding value. So it did add value. So they started to look into it further. And there's been a new explosion of, you know, surgical liaison services that really look at frailty and frailty tools as added value to the assessments and to identify risk and stratify and personalize care. In oncology, the same thing has happened. So you know, how you tailor treatment intensity, how you actually predict the response of the individual to these big stressors that are chemotherapy and surgeries. You know, so essentially, you know, it's been adding value, and there's a lot being written about, you know, how frailty paradigm can help outside geriatrics. And if you're around for the World Congress of Geriatrics, we will have a FROG symposium, which is the Frailty Outside Geriatrics Symposium. So you'll be hearing a lot more about that. Pharmacotherapy as well. So pharmacists are not available everywhere, and frailty pharmacists are very useful in frailty services because prescribing in frail older people is very complex, because obviously these people have not been part of the clinical trials. So the adverse reactions can be almost unpredictable. And we really have to think twice and knowledgeable about, we have to be knowledgeable about how these medications actually act and what physiological systems have deficits to try to anticipate how the organism is going to react to the stressor. And a lot of that requires knowledge and expert knowledge being around us. And I find pharmacists are very, very helpful as part of frailty teams. We should have more of them, actually. Sometimes, you know, frailty can be the great confounder and the great forgotten when it comes to the development of drugs. And even the European Medicines Agency had a very good initiative before they relocated to Amsterdam, looking at the possibility of incorporating frailty measures and cognitive measures routinely as a demand in the process of approval of new medications that are undergoing clinical trials for regulatory approval. And I welcome that development extremely because you know, stratifying populations according to risk is what we really need to do. I've covered this, Olga. I will leave some time for the comments as well. But I think it's very important that we think about how people perceive the concept of frailty outside our clinical practice. And what I mean by frailty, and you know now I mean by frailty, is not what you thought I meant by frailty before I started speaking, but also is probably not what someone out there in the street at the moment thinks that frailty might be. Because if you ask, you know, people on the street what frailty is, well, they tell you what you see there, that, you know, there's nothing to be done, is end of life care, and it's a very negative and irreversible thing. And actually, that is not what we mean by frailty. And we cannot be tired to really emphasize that educational point, because it really needs to be emphasized outside our clinical focus. And a lot of people say, well, look, doctor, you say that I'm frail, but I'm not a failure. You know what I mean? And you know, and that's absolutely right. And when we label clinical services with the word frailty, we have to be cognizant and aware of what might be doing in terms of, you know, giving people the wrong perception. So we can explain it, and we have to explain it. We should explain it, you know, if we really choose to label services in the name of frailty. Once people know what you mean, it's all fine. You know, the problem is when you don't have time to explain it. And of course, you know, I really had the opportunity to surround myself with philosophers, anthropologists, sociologists, and actually, it's very interesting what they say to you when you meet around a round table and you explain the concept and say, well, you know, I didn't know that you were looking at frailty this way, because, you know, we are detecting frailty being around that other way. And so I think it's important to appreciate that frailty not only has clinical concept, but also it's an existential and lived experience. It's a contingent aspect, and sometimes, you know, implementing frailty paradigms can have unintended consequences, which are not bad in themselves if they're going to open that debate and communication and interdisciplinary reflection that this field really needs. So with that, I think I'm going to close it. I think there's no question, as you can see from this series, that frailty is one of the new frontiers of medicine. And I think it's going to be an opportunity for debate, and I'm looking forward to that. And apologies, Olga, if I'm running out of time.
That's okay. Thank you so much, Roman. That was a great overview of the concept of frailty. I think I'm sure the audience would find it very useful, and it's actually a very well attended seminar. And we have some questions from the audience. You can see them in the chat or in the Q&A tab, but I will also repeat them so that the audience can hear the question, because I don't think they can see it. So there's a question from Gustavo Vargas from Miami, VA. And are we starting to see frailty in a younger population due to lack of physical activity, poor eating habits, stressful lifestyles, e-smoking, and obesity? And if so, how is the primary sector addressing this issue? And lastly, what frailty assessment can be used in the younger population?
Well, it's a very complex question, Olga. As you well know as well, frailty departed from geriatric medicine, I suppose, and the validation of the frailty tools that I've discussed occurred in populations that were more than 65 years of age. Whether frailty applies or does not apply to younger populations, well, look, I will say as a concept, it does apply. Whether you want to call it frailty or not is also a matter of debate. The conceptual model of baseline stressor and dysregulation does definitely apply. And in fact, you know, I would argue that a lot of what is being done in medical specialties and surgical specialties in younger populations, they already apply that model, and they don't call it frailty. They call it, risk prediction, risk stratification, and they have their own tools, and there's been a lot of research in their independent specialties. So sometimes I think, why would we want to call it frailty? Because, you know, the concept is similar, but they also have developed a lot of research. The other aspect that is coming to my mind as well is that frailty is an issue from a conceptual point of view in younger populations. In our Trinity modules, we talk about special populations such as HIV, intellectual disabilities, sometimes oncology, cancers in younger populations, survivorship, cancer survivorship. So it's nothing to do with chronological age, but I do realize also, without really trying to be, you know, imperialistic from a conceptual point of view, that actually, you know, what we call frailty as a concept, it's already been very well studied in younger populations. Sometimes, you know, the rehabilitation services for people who are younger but are becoming frail are a bit more challenging, because in geriatric medicine, we work in a multidisciplinary environment, and we have access to a lot of allied health professionals that help us with rehabilitation process. And in some countries, you know, access to that is limited to those who are 65 or more. And of course, you know, it's important, as we've seen also in COVID, to try to change that paradigm that, you know, people can and maybe do need often allied health professionals and more geriatric-like rehabilitation services, even though they are not really 65 yet. So, but that's something that can be also discussed and explained even outside the label of frailty, because sometimes, you know, younger people don't like to be labeled with frailty, as it is the case also in many older clients that sometimes complain because we have labeled them as frail.
Great point. There's also a clarification question about the length of stay slide. Why was there a decrease in length of stay in the most frail?
Well, very good. And thanks for the question, because it denotes that you were paying attention. So of course, inpatient mortality and length of stay are a trade-off, aren't they? So those who are at very high risk, they might experience that mortality sooner. So therefore, when you get to very high levels of frailty, length of stay could be lower on average because many of those clients perhaps died. So that's a very good point. There's a trade-off between hospital operational metrics. Good, well noted. Thank you very much.
And we are 2:01, so I think I will need to wrap up now. And thanks so much, Roman, for such a great presentation and so informative. And also I would like to thank the audience for questions they are raised, and I'm sure they were paid a lot of attention in your interesting slides. I just want to let everybody know that after the end today, you will receive through email a short survey about your today's presentation, so you can do an evaluation. And please fill out the survey, and also don't forget to register for our next session on June 8th. There's actually a change in the schedule. The presenters for June would be Dr. Mario Ulises Perez-Zepeda from Mexico, who will present on frailty education in the era of social media. And on behalf of the organizing committee, I would like to again thank Dr. Romero-Ortuno for his presentation, and also our audience for attending our seminar series. For everyone, stay healthy and safe, and thank you for being here.
Thank you so much, and stay safe and well wherever you are. Thank you.